So, welcome to Curbside Consult. I'm Harold Pollack at healthinsurance.org, and with me I have the great Jonathan Gruber, one of the nation's leading health reform experts and reputed to be the architect of both Romneycare and Obamacare, among other things. By the way, it's quite a backdrop you have there, John.
It drives my wife crazy that I do these Skype things in front of my messy office shelves, but...
Actually, what you really should do is turn around and pull and have it and reveal that it's actually a poster. And
poster of the messy professor.
Yes. So how are you feeling about the Affordable Care Act today?
Feeling pretty good. I mean, I think that, certainly reports of its demise are greatly exaggerated, as Mark Twain would say, and it is looking as good as we could hope at this point. But the bottom line is, it's still too early to know for sure. We know it hasn't failed. Mm-hmm. We know that we have enough people, so it's working. But we don't know really the two critical things. One is we don't know how many people have actually gained insurance coverage. Mm-hmm. And we also don't know really enough about the health mix of who's in and what's going to happen to premiums.
So when will we get some information about that last point?
Well, the information is going to start to come out this summer. What we have to be careful about, it's going to come out in dribs and drabs. In particular, the states where the numbers are bad might release them first, because the states that sort of oppose Obamacare might run to release their rates, saying, look how much rates went up. Mm-hmm. I think we have to be very careful to wait till the rates are in from everywhere, including places where Obamacare went well, like California, and then look at aggregate effect. And I think the relevant benchmark is 10%. Doing some research now, which will be out in a few weeks from the Commonwealth Fund, which shows that if you look at the rate filings from the individual insurance market in the pre-ACA period, the average annual rate of growth was 10 to 11% in the individual market. So that should be our benchmark. I don't think, given how early we are on the cost control efforts of the ACA, I don't think we should be that locked into beating it. But I think if we come in single digits, that's a big win. If we come in 20% plus, that's a problem. And I think we're just going to have to sort of see where it comes in relative to the 10 or 11% it was going up beforehand.
Well, one thing I like about that, what you're just saying, is with all the political polarization, it's nice to have a couple of numbers that are basically hard to fudge that would give us a genuine market signal about how at least insurers perceive it's going. Because
Exactly. I think, the enrollment number was never the 7 million, the elusive 7 million. That was just a CBO projection. That was never a normative guide to anything. It got a life of its own, partly the administration's fault. And partly I'm a bit disappointed that they're touting 7 million because, once again, they're giving these CBO numbers a life of their own, when really they should just be saying, look, the exchanges are working. That's what matters. The first hard numbers we'll get that matter will be rates, and those will start dribbling out this summer.
Are the sort of website problems basically behind us at this point?
At the national level, yes. Not in a number of states, including my own state in Massachusetts, website problems remain. But the national website, actually, it's amazing how quickly they fixed it. It was about a 6-week problem. By mid-November, things are working pretty well. And so actually it's well behind us at this point.
Do you think there are any lessons for future public enterprises of this sort from the difficulty in rolling out this website?
I think there is. I think I've lived through this in Massachusetts. I'm on the connector board here, so I've seen kind of our own snafus. And I think the lesson is that when you have a major government project like this, you tend to have too many folks trying to run it. And there needs to be one point person who has the final say, who reports directly to the president, in our case directly to the governor, who has the absolute final say over everything. In Massachusetts, and I think in the federal government, they had too many different people giving orders, and that led to a lot of the problems. I think the other lesson is that you need to sort of be modularly testing. My understanding of the federal government, what we've seen in Massachusetts, is there's promises these big deliveries, and then you're waiting, it doesn't come, and all of a sudden you've got nothing. We need to sort of focus on smaller, more modular deliveries along the way.
Mm-hmm. I must say that I feel as culpable as anyone for not anticipating some of the problem. Not that I had any influence over anything, but a lot of people like me who were very focused on the policy disputes really were not necessarily focused on the nuts and bolts public management of doing the thing. And
I actually got into some trouble here in Massachusetts because when we found out that our website was a real disaster, I sent an email, sort of a mea culpa email around to the board members saying, look, we sort of messed this up. And part of the reason we messed this up, not totally, we were a very small part of the problem, but part of the reason we didn't catch it is because we all like working on the policy stuff. That's more fun. And basically, the exchanger worked so well in Massachusetts for so many years, we kind of figured it just run on its own, and we were just focused on the policy issues. So I think a lot of us made that mistake of not realizing how important the IT was.
So we're here at Curbside Consult at healthinsurance.org, and I'm talking with MIT economist Jonathan Gruber. By the way, now you have a new professorship, I see. By the way, congratulations.
I'm the Ford professor. When I got it, my mom said, "Oh my God, that's not Rob Ford, is it?" And I said,
yeah, you guys actually have a lot of similarities. That's, there's no doubt about it. You mentioned that we don't really know how many people who were actually uninsured who've now been covered. Now, it seems to me that a lot of the public conversation about this is a little screwy in terms of the way I was trained, because first of all, there's a lot of the conversation concerns people on the exchange who are uninsured, and there were a bunch of people who came into the Medicaid program who are uninsured who tend to be ignored. But also that if we think of health insurance as a sort of dynamic process where you move from, I'm covered because I have a job, and then I lose my job and I might become uninsured. You could imagine almost everyone in the exchange could be coming from previous insurance coverage, but because we're preventing them from becoming uninsured, that over time we would actually erode the number of uninsured quite substantially, even if at any given moment in time it doesn't look like we're reaching that many of the uninsured.
That's exactly right, Harold. And I think, that's why in some sense, to know what effect there is in the uninsured, we can't go by these surveys of guys in the exchange. We've got to actually wait till the next population survey of the uninsured comes out and make the apples-to-apples comparison of the sort of point. We have a point-in-time measure of the uninsured before the ACA. We need a point-in-time measure of the uninsured after. That's going to be very different than what we're seeing from these surveys about who was uninsured who came on the exchange for the reason you say. Also because insurance is so dynamic. I just published an editorial in TPM with John Graves. We went through the numbers on turnover. In a typical year, about 7 million people lose health insurance. Or last year, about 7 million people lost health insurance. In 2012, we have the date. 7 million people lost health insurance. 3.6 million of them were because they lost jobs and lost their health insurance. So that's 3.6 million people that year who over the course of the year would be coming to the pool of the uninsured. That's not accounted for in these numbers. So I think it's really just too early to say.
I was trying to explain to reporters that if they just understood that health insurance is a continuous time Markov chain, it would all basically be very straightforward. And
I'm sure that goes over really well.
It did go over really well. I also made a lot of jokes about data versus datums in the same conversation. So it went well. Do you think that, as you mentioned, the 7 million number is not particularly a key number in the fundamental issues around health reform, but it is an accomplishment to have hit it, and it's one that many people didn't think that the administration would be able to hit. Do you think that this will change the politics of ACA in a meaningful way?
Yeah, and I think 7 million was important as a political number, not as a substantive number. And I don't know if it'll change the politics. Basically, I think everyone who is opposed will remain opposed, everyone who's for will remain for, but hopefully it'll tamp down the debate a little bit. Basically, it's reminiscent of the people who were saying Romney's going to win for sure when the data clearly showed he was going to lose. These unskewing folks. And basically the question is, will folks start to admit? You're starting to hear people on the right saying, look, we've got to admit this is the law of the land and we've got to fix it. I think that's great. If that conversation, I'm all for talking about sort of bipartisan efforts to improve this law. I have no problem with that. But we've got to start with accepting it's the law, and hopefully hitting these kind of benchmarks will move us closer to that.
It seems so far the only real bipartisanship is between the Obama administration and some Republican governors. And in Washington, there's really no bipartisanship that's operational at the moment.
I think you're right.
And I think that's because these governors just have responsibilities for hundreds of thousands of people. And, if I'm a typical representative in the House, I'm not responsible for anything in any meaningful way.
Well, I think, Harold, the single thing we probably need to keep the most focus on is the tragedy of the lack of Medicaid expansions. I know you've written about this, you know about this, but I think we cannot talk enough about the absolute tragedy that's taking place, really a life-costing tragedy that's taking place in America as a result of that Supreme Court decision. You know, half the states in America are denying their poor citizens health insurance paid for by the federal government. So to my mind, I'm offended on two levels here. I'm offended because I believe we should help poor people get health insurance, but I'm almost more offended as a principle of political economy. That basically, if you told me when the Supreme Court decision came down, I said it's not a big deal. What state would turn down free money from the federal government to cover their poor citizens? The fact that half the states is such a massive rejection of any sensible model of political economy. It's sort of offensive to me as an academic, and I think it's nothing short of political malpractice that we're seeing in these states, and we got to emphasize that.
It's one of the things that's really striking to me is there's a politics of impunity towards poor people, particularly non-white poor people, that it's almost a feature rather than a bug in the internal politics in some of these states not to cover people under Medicaid, even if it's financially very advantageous to do so. And it's really, I think there's a really important principle to defeat this politically, not just because Medicaid is important for people, but because it's such a toxic political perspective that has to be shown that approach to politics doesn't work, because otherwise we will really be stuck with some very unjust policies that will be pursued with complete impunity in some of these places.
You know, that's a great way to put it. There's larger principles at stake here when these states are not just turning down covering the poor people, but turning down the federal stimulus that would come with that.
Yeah.
So the price they're not just not interested in covering poor people, they're willing to sacrifice billions of dollars of injections into their economy in order to punish poor people. I mean, it really is just almost awesome in its evilness. And I agree. We have to recognize there's larger principles at stake here.
By the way, one of the real ironies is an awful lot of the institutions that would get the checks from Medicaid are in the public sector. So they're also every city and county and correctional system and public hospital, it desperately wants this. And in Texas, the Harris County and the city of Houston, they desperately need that money. And it may be what becomes a political forcing event will be some public hospital going out of business or something like that that forces them to think differently. Or it may be that just we have to wait until President Obama leaves office because it's the centerpiece of his presidency and it's just too hard to do while he's sitting in that chair.
I mean, Harold, look, if we look at the original expansion of Medicaid, it took about 5 years to get all the states in. And really, it was sort of proceeding at a similar pace. I mean, for the first few years, they didn't even have half the states. So I think we don't have to panic at this point. History does suggest that we can overcome this, but it's just very sad along the way.